So this is a repetition of yesterday's lecture, the step for ABG analysis. First step was, let me use my marker. Okay, first step was check pH to determine the acidosis or alkalosis. This is the primary disorder. After determining the primary disorder, you will go for the calculation or determination of the compensation, whether the other system is overdoing, underdoing, or the other system is compensating adequately, appropriately. After doing that, if it is metabolic acidosis, you have to calculate the anion gap. Now, in case of anion gap, either it will be normal anion gap or it will be high anion gap. In case of high anion gap, if the albumin is given, you will adjust it. And after doing that, you will calculate the delta ratio. Now, what is delta ratio? We will be doing the practice and I will try to make you understand what is delta ratio. What is delta or delta ratio, delta gap? These all are actually interchangeable terms which we use for the same thing. This is actually a formula that is used in cases of high anion gap metabolic acidosis. When there is high anion gap metabolic acidosis, you have to look for another disorder, the third disorder. Okay, to evaluate whether there is a mixed acid-base disorder is present, also known as third disorder. So how we will be doing that? We will be using a formula. I will show you. So it is calculated to check whether a decrease in bicarb is purely due to high anion gap, also known as HAGMA. First of all, I will tell you what is HAGMA and what is NAGMA. We will be using these terms from now on in our this session. And HAGMA is the high anion gap metabolic acidosis. Okay, HAGMA is high anion gap metabolic acidosis. Now, what is NAGMA? NAGMA is actually the normal anion gap metabolic acidosis. It is NAGMA. So just keep these two terms in mind, HAGMA and NAGMA. So when I will be saying HAGMA, it means high anion gap metabolic acidosis. And when I will use term NAGMA, it means this is normal anion gap metabolic acidosis. All right. So when you have a patient with high anion gap metabolic acidosis, when the patient is having high anion gap HAGMA, then you have to check this decrease in bicarb in this patient is either purely due to HAGMA or there is some associated disorder as well. Now, what is the delta? Delta means difference between the two values. Now, delta bicarb means difference between the two values of the bicarb. One is a normal bicarb and then other is a given. The normal bicarb we know is 24. We take 24 as normal. And the given bicarb, that will be on ABG's report. Anion gap, delta anion gap. Delta anion gap means first there is a given anion gap and then the normal. We know the normal anion gap is 12. The given anion gap is that which we calculate from the values of sodium, chloride, and bicarbonate. So we calculate it. So after getting these values, we will put these values in the formula and we will get a result. And I will tell you what is that. Now, this is the formula. Delta ratio is actually, we divide the difference of the bicarb values over the difference of the anion gap. Now, how to interpret it? Now, this is very interesting actually. First, we will go to the HAGMA. When we are having a value ranges between 1 to 2, it means that everything is fine. Not like fine, but it means that actually the patient is having only HAGMA. Patient does not have any associated disorder, any third acid-base disturbance along with HAGMA. So patient have only HAGMA. You can just kindly take the screenshot of this one, okay? Now, when the values are more than 2, After subtracting, dividing all the values, now we get an answer that is more than 2. When the answer is more than 2, it means that patient is not only having hagma, but there is also associated disorder of metabolic alkalosis. I will give you some examples at the end, okay? That how come patient will have hagma and metabolic alkalosis side by side. I have some examples saved for the later, okay? Now, when the value is less than 1, it means that patient is not only having hagma, but also patient is having nagma. Patient is having high anion gap metabolic acidosis, as well as patient is also having normal anion gap metabolic acidosis. We will be doing the exercises first of all, and second I will give you some examples, and then you will understand it fully, and you will just capture the whole this whole concept of side by side parallel disorders, that how come patient is having high anion gap and patient is also having non-anion gap, how come. So I will give you some examples, and you will also be doing some exercises, and then you will understand this whole concept. This first slide is normal anion gap metabolic acidosis. Now, this is a pure high anion gap metabolic acidosis. Now we will go for the calculations. As you can see, sodium is 140 and the bicarb is 12 and chloride is 104. Now, just putting all values in the formula, we will get an anion gap value that is 24. Now 24 is high, which means that the patient is having high anion gap metabolic acidosis. When the patient is having high anion gap metabolic acidosis, you have to put these values into the delta ratio formula. That is here. Now we have the value calculated. The calculated anion gap value is this. Let me use the marker. Okay, we have calculated this, the 24. We will put these values in the formula. The given anion gap is 24. The normal anion gap we all know is 12. Now, what is this 24? What is this 24 here? It is a normal bicarb value. And what is this 12? This is a given bicarb. Given bicarb is this. After putting these values in this formula, we are getting answer is 1. And if you can recall my previous slide, I have mentioned there, when the value is around 1, between 1 to 2, it means the patient is having only hagma, high anion gap metabolic acidosis. Now let's go to the third example. Now you can see the calculations here. Now see, here bicarb is 19, chloride is 97, and sodium is 140. After putting them in the formula, we will get a 24 high anion gap. So this is high anion gap. When you get high anion gap, you have to do the delta ratio thing. Okay. Now, after putting all the values here, what we get? Let's see what we get. This is the 24. 24 is what? 24 is the calculated, this one, calculated value of anion gap. The 12 is normal value of anion gap. Now, what is 24? 24 is the normal value of bicarb. And what is 19? 19 is this bicarb that we get on ABGs. After putting this value, we got an answer of 2.5. And if you recall the previous slide, where I have mentioned, when it is more than 2, it means the delta ratio is increased and patient is having hagma and patient is also having metabolic alkalosis. Now you will say, how come patient is having metabolic acidosis and metabolic alkalosis at the same time? I will give you an example afterwards. Okay, just keep this in mind that this can happen. And this is happening in our patients, which are very complex patients in ICU with multiple diseases and complexity of diseases. So in such patients, we may find these two things side by side, hagma and plus metabolic alkalosis. I will give you an example afterward. Okay. Moving to our next slide. Okay, this is our next slide. Okay, this is the same. This is same. When there is the answer lies between 1 to 2. The values lies between 1 to 2. That means it is only hagma. Now, coming here, we are having the values of, look, this is bicarb is 6 and chloride is 110. After adding up and subtracting, we are getting a value of 24. Now we will put the values here and we will get an answer of 0.7. See, this 24 is the calculated, this one, calculated anion gap. The 12, the normal anion gap. This 24 is the normal value of bicarb. This 6 is this 6. We get the bicarb report on the ABG. After putting this in this formula, we will get the answer 0.7. And we have learned that when the value is less than 1, it means patient will be having high anion gap plus normal anion gap. Now you will say how come patient is having the side by side two metabolic acidosis with normal anion gap and high anion gap. I will give you an example and you will be like, oh, all right. So first tell me that kindly tell me that up till now everything is clear. You just need few examples and you will be like, okay, that's cool. Now tell me, everybody, that have you just understood this for usage of the formula, the how to use this formula of delta ratio? Kindly, please just inbox me so that I can go to my next slide. Okay. Only one person is saying yes. Okay. Aisha, Ali, yes. Okay, good. Ikram, Jennifer, and Saima. Okay, Aruj. Okay, good. Cool. So you all understood. So let's go to our next slide here. So now you know how to use this delta ratio, okay? Now you know how to calculate, how to go further after when we are having a high anion gap, we have to first adjust it. If we have albumin, we will adjust it. And if we don't have albumin, then it's fine. Just go for the delta ratio. Now there's an example. I will solve it for you. You can also join me to solve it, okay? Now these are the values here. Now you have to tell me that what is this disorder? This is very easy. Bicarb is low and the respiratory acid is low. Bicarb is low, it means that pH is acidic. It means that patient is having metabolic acidosis. Now you have to see whether it is compensated or not. What was the formula for to calculate the compensation? I have mentioned this formula here. Now you have to multiply it. 1.5 multiply with 6. Let's do it. Where's my calculator? Okay, now we're having 9. 9 plus 8. 9 plus 8 is equal to 17. And then it is plus minus 2. Plus minus 2 means either it will be 19, the range will be 19 or 15 to 90. Now, tell me, it is compensated or it's because it's 19 and we are having 20 here, so it's not too much less. It's appropriately compensated or not? Now tell me, everyone. Okay, I'm getting the answers. 15 to 19. Yes, you're right. 15 to 19. 15 to 19 is the range. Now tell me it's compensated or not. 15 to 19 is the range. So it looks like it's respiratory acidosis. Okay, you're saying it is respiratory acidosis. Is it less than the value compensated? Let's see what is the answer. Okay, let me clean this slide. And suspense is rising. This is respiratory alkalosis. I don't agree with this because this is not my slides actually. I have shared this. I have taken the screenshots of some slides from the internet. I don't think it's respiratory alkalosis. How come it's respiratory alkalosis? It is very good. It is adequately compensated because we just got a value between the 15 to 19. I don't agree. Actually, this is not purely my slide. I have taken it from internet actually. It is compensated or not? It is a debate here now. Come on, tell me it is compensated or not. Don't just look at this answer. I don't agree with it. We are having a value of 15. Expected value is 15 to 19. First of all, just make this thing clear. And patient is having 20 PaCO2. That is not not very high from the 19. We can say it is respiratory acidosis, or we can say it is compensated. I will go for the compensation. I think it is compensated. Yes, Jennifer, I agree with you. It is compensated. Okay, let's go to our next part. Okay, now when there is metabolic acidosis, you have to calculate the anion gap. Now let's go for the anion gap. Okay, now anion gap is 29. As we know, this anion 29 is higher. High anion gap. When we have high anion gap, we have to go for the delta ratio. Now, after just using all these values, this is 29. 29 is the calculated anion gap. 12 is a normal value of anion gap. 24 is a normal value of bicarb. And 6 is the bicarb report on ABGs, bicarb value on the ABGs. So we are getting a value of less than 1. So when it is less than 1, so what is that? Just recall the slide. Hagma plus Nagma. Okay, Jennifer is saying it's Hagma plus Nagma. Hagma plus Nagma, Hagma plus Nagma. Okay, everyone is saying it's Hagma plus Nagma. So yes, it is Hagma plus Nagma, and this is compensatory respiratory alkalosis along with patient is having also respiratory alkalosis. Although I'm still not in favor of respiratory alkalosis, but anyways, after applying the formula, this is a compensated respiratory system here, and Hagma plus Nagma, these are true for sure. The patient is having Hagma plus Nagma for sure. This is another way of, this is another formula to calculate the delta gap and to identify whether there is a third disorder or not. So it has different values, like the interpretation of it is here. Okay, over here, if it is more than +6, it means that patient is having Hagma plus metabolic alkalosis. And if the value is less than -6, it means that patient is having Hagma as well as Nagma. So this is a formula of delta gap. So you can use delta gap as well, but I usually prefer delta ratio because I am more used to it. So I just prefer that. So it's just all about your preference, that what you use, but the results will be same. Whatever you use, you should know how to interpret it later. Okay, so this is the formula which they have simplified it to this. A 75-year-old woman presented with fever, diarrhea, and these are her vital signs. Patient is in shock, like patient heart rate is this and BP is this. Now these are the ABGs. This is sodium, this is potassium, this is chloride, this is bicarb, and this is our blood glucose level. Now, first of all, what is this? pH is low. It means patient is in acidemia. Due to what? Bicarb is low. So this is metabolic acidosis. First of all, this is metabolic acidosis. Now you have to see whether this metabolic acidosis it is compensated by respiratory system. So it is fully compensated or not. So this is a formula. Appropriate compensation you have to see. Oh, they have already given the answer. It is appropriately compensated. Okay, anyways, this is appropriately compensated. Now you have to calculate the anion gap. Go for anion gap. I have already just put the readings in the formula. So we have the answer here. It is 20. That is elevated anion gap. Now when we have high anion gap, we will go for delta ratio. Now you have to put the values in the delta ratio formula, and then you will tell me what is this. Formula is the given. The calculated value subtracted by, it is 12, subtracted by this, then divided by the normal value of bicarb, and the given value of bicarb is 14. Now, come on, everybody, just calculate it. Oh, this is a simple answer. This is 0.8. So this is the value is less than 1. So what is meant by the value of less than 1? Can you tell me what is meant by a value of less than 1? Can you interpret it? It is a hagma. Okay, good. Let's see what is this. Let's see our answer. Our answer is yes, you all are right. It is hagma and nagma as well. Now this patient is having both the disorders, hagma and nagma as well. Okay, let's solve our other example here. The third example. Now come on, do it. So this is respiratory acidosis. Now let's see it's compensated or not. The respiratory acidosis have to be compensated with what? It has to be compensated with metabolic component. Now let's see how it's compensated. So as you all know, this is the way of compensation. For every 10 rise or fall, rise in PaCO2, there should be a rise of 1 bicarb for every 10, a value of 65 here, which means for every 10, it has to be 1. So we have 35 actually. It has raised 35 mmHg. So bicarb should be 1, 1, 1, and 0.5. Let's say 1. Now, there should be a increase of bicarb by 4 millimoles. So the normal value of bicarb is 24. It should be 28. But patient is not having 28. Patient is having 22. It is less than the expected. It should be 28, but patient is having 22. Because it is less than expected value, it means patient is having what? Patient is having what? First of all, it is not compensated, okay? As you can see, we're expecting it to be 28, like around 28. But it is not, a patient is not having a 28 bicarb. On ABGs, it is 22. It is less than expected, which means patient is having what? Come on, everyone. Yes, it is uncompensated, Jennifer and everyone, but what is this? Yes, Saima, exactly. Very good. You are right. It is metabolic acidosis. Well done. Jennifer, you have to tell this. What is the disorder here? I'm repeating it again and again that you cannot say it is partially compensated, it is not compensated, it is uncompensated. We cannot use these terms because these are no more in use. You have to mention the disorder. Ali, you're also right. It is metabolic acidosis. Humaira, acidosis. Yes, Jennifer. Yes, metabolic acidosis. Good. You all are right. So let's clear the slide and let's see what is the answer, and either of us are right or wrong. So yes, it is metabolic acidosis. Now patient is having respiratory acidosis superimposed with metabolic acidosis. Now when there is metabolic acidosis, what we do next? We look for anion gap. Here it is 16. And as they have mentioned the albumin, so you will adjust the anion gap. Now you will be having an answer of, let me do it for you to save the time. So it is 22. As you can see, this is 22. This is high anion gap. Now patient is having not only respiratory acidosis as well as high anion gap metabolic acidosis. Now when we are having high anion gap, we will go for delta ratio. Now you have to put the delta ratio, okay? You have to put the values in the delta ratio. Now the calculated anion gap is 22. We have to minus what? Minus 12. Then this is normal value of bicarb, and what we got here, we have 22 on ABGs. So it will be some like this. 24 minus 22 is 2. And yes, we will get answer of 5. So when it is more than 2, how do we interpret it? Come on. Yeah, okay, good. Let's see. Either all of you are right or not. Let's see. 5. And it is, yes, you all are right. Patient is having respiratory acidosis, and that is associated with high anion gap, that is hagma, and then patient is also having metabolic alkalosis. So now you see patient can have multiple disorders at the multiple acid-based disorders at the same time. Yes, you all are right. Well done. So now you know. So now everybody of you know that how to use the delta ratio, the formula, how to use it. Now let me give you some examples. Like now, what causes mixed nagma and hagma? Now, how can I say that patient is having high NN gap and patient is same patient in the same blood is having non-NN gap? How come? When in the early uremic acidosis or early renal failure of interstitial nephritis. So these are some examples. And of course, the reason was most likely hyperkalemia superimposed in advanced tubule interstitial disease and simultaneous use of ACE inhibitors. All right. So this is the one example, early uremic acidosis or early renal failure with interstitial nephritis. This is a one example of hagma plus nagma. Now let's go to the second example. That is my favorite one. How can a patient is having metabolic acidosis and metabolic alkalosis at the same time? Yeah, that can be happening. Yeah, of course, that can happen. Like in case of hypovolemic induced lactic acidosis, that is, you can say one type of shock in a patient is in shock and the cause of shock is vomiting induced, the vomiting due to the vomiting excessive vomiting, patient is in hypovolemia, so there will be lactic acid production in the body which will lead to hagma. But because of excessive vomiting there will be loss of chloride and bicarbs and all that from the stomach, so it will lead to metabolic alkalosis as well. So patient will be having hagma, high NN gap metabolic acidosis, and he will be having metabolic alkalosis as well. Two things same time. Now you got it or not? So let's just complete this respiratory component of the ABGs. That is way more easier and very easy actually, uh, because the NN gap and the adjusted NN gap and then the double gap or smaller gap and then the delta ratio, delta gap, those are a bit complicated concepts in the ABGs. The respiratory component is very easy. Let me explain it. Okay, where's my marker? So this is, okay, acute respiratory acidosis. First, we will go for acidosis, acute and chronic acidosis, and then acute and chronic respiratory alkalosis. In acidosis, because we call PaCO2 the respiratory acid. So in respiratory acidosis, PaCO2 will be raised. Now, how the compensation will occur for acute and chronic respiratory acidosis? For every rise of 10 mmHg of PaCO2, there will be a rise of 1 millimole of bicarb for every 10. Okay. And then for the chronic cases, there will be rise of 4. Bicarb will be rise by 4 millimole for every 10 mmHg. Now, if we get a value, like for example, now let me tell you, like for example, we are expecting by using the formula or this method, let's say we assume or we expect the bicarb, rising the bicarb to be up to 28. Let me use the other marker, sorry. Okay. Now let's say after using this, you reach to this value and you think that the expected bicarb should be 28. But on ABGs, it is 22, which means it is less than the expected. So what does that mean? It means patient will be having not only respiratory acidosis, but also superimposed metabolic acidosis, as you all have done it in exercise. Okay. So it will be superimposed metabolic acidosis. But let's say the expected value was 28 and patient is having 32. It is higher than this. So alkali is more. Alkali is more than the expected one. When it is more than the expected one, it means patient is having metabolic alkalosis as well, as a secondary disorder to the acute respiratory acidosis. Okay, this is simple. Now, when you have an ABG, First of all, you, after looking at the pH and everything, you just have to look at the PaO2. Then you have to look for the pH ratio. Where's the pH ratio here? I didn't mention it here. Yo, okay, let me do it for you. Because we are doing the respiratory component, so when you have an ABG, you have to go for the pH ratio. This is pH ratio is short of actually PaO2 divided by FiO2. What is AA gradient? AA gradient is the partial pressure of, this is AA gradient. This is also written as like this, AA gradient PaO2. This small o is for, this small a is for artery, and this capital A is for alveolar component of partial pressure of oxygen. Okay? Okay, so that will be in the alveoli and that will be in the arteries. Now, what we're doing here, this is the formula of calculating PaO2. First of all, because this value, we can get this value from ABGs, but how can we get this value, the PaO2, the alveolar component? How can we get this value? So this is a formula, this one here, formula to calculate PaO2. When you get PaO2, then you subtract PaO2, the small a PaO2 from this, and then you will get the AA gradient, the value of AA gradient. Okay, the difference should not be more than 15, and in some books it is also written as difference should not be more than 20. It should be less than 20. So we will go between the 15 to 20. Okay. Let's go to our other slide. Now, as we were doing in the metabolic acidosis, there we were learning the causes of the high anion gap and the normal anion gap metabolic acidosis. Now here we are having a normal AA gradient hypoxemia and high AA gradient or elevated AA gradient hypoxemia. So these are the two different causes. So if you're having a normal AA gradient and still there is hypoxemia, so you can go for these causes like low inspired oxygen content, alveolar hypoventilation due to any reason, and then low mixed venous oxygen concentration. And if your patient is having a high AA gradient, means more than 20 value of more than 15 or more than 20 mmHg. So it means that patient may be having VQ mismatch, there is shunting or diffusion issues. In VQ mismatch, we can have obstructive lung diseases, pulmonary vascular diseases like pulmonary embolism, the most important cause, and maybe pulmonary edema, interstitial lung diseases, atelectasis. Shunting means either it's anatomical shunt like ASD, VSD, or there may be physiological shunt like atelectasis, ARDS, pulmonary edema. Okay. So because the causes are different, so their treatment will be different, the management will be different. This is a sample of ABGs. We will do it later. I have saved this for you. Now, hands-on session. Come on, everyone. Wake up and let's finish this. And if we left any time at the end of the session, I will go for VBGs or otherwise not. So hands-on session is here for you. The formulas is, you know the formula, you know the drill. Now let's do it. Okay, a post-operative patient is noticed to be cyanosed with shallow breathing. This is pH, this is CO2, which clearly shows that, and this is PO2. It looks like patient is having hypoxemia and patient is having respiratory acidosis. Now, because we're doing the respiratory component, our focus will be more on hypoxemia and causes of hypoxia and all that. Now, is the hypoxia simply due to the hypoventilation, due to residual anesthetic effects, or he has also aspirated and developed lung parenchymal problems? Now you have to differentiate between the two. Either patient is hypoventilating due to anesthetic residual effects, or patient has aspirated and he has developed lung parenchymal problem. Now for that, what you have to do? You have to do the exercise of AA gradient. Now tell me what is the AA gradient here? Because they have mentioned the room air. Patient is on room air. How will you do it? Oh, answer is given. Come on. Now tell me what is the AA gradient? What is the answer? You have to use the you have to use this formula, this one. FiO2 multiply with 713, then subtract PaCO2 multiply with 1.2. Now I am writing the formula here. Oh, no, the other marker. Okay, FiO2 multiply with, it's multiply with 713 minus CO2 multiply with 1.25. Now I have mentioned the formula here. I have written the formula. Now use it and tell me. First, you have to calculate PaO2, and they have given the value of small PaO2 here. This is PCO2. Now put all the values. The patient is on room air, so he will be having a 0.21 FiO2 multiply with 713, and all other it's 80 multiply with 1.25. Now come on everyone, wake up, be active and do the drill. Okay, first of all, we are getting answer of 49 and we have to subtract 37 from it. And of course, we will get an answer of 12. So now it's the answer is 12. So this falls in the normal AA gradient. So what were the causes of normal AA gradient? Now tell me, what are the causes of normal AA gradient? Either it's due to hypoventilation or it's a lung parenchymal disease. Now come on, your answer is correct. It's 12. Good. But now you have to tell me that what is the cause of this? Your answer is right, everyone. But now you have to tell me that because it is 12. So what is the cause? It's due to hypoventilation or it's due to lung parenchymal disease? Okay. Sumaira is saying it is hypoventilation. Okay, D is saying it's alveolar hypo. Yes, good. I think it's hypoventilation. So let's check the answer. It is largely due to hypoventilation. Good. So your answer is correct. Well done, everyone. Okay. Yes, Ikram, your answer is right. Jennifer, good. Aruj, yes. I want D. D is Pardeep now. Pardeep, you're D here? Yes. Okay. Yes, everyone, your answer is correct. So let's move to our next slide. Now, this is our next exercise. A patient has been brought to emergency department after head injury. She is deeply unconscious and her ABGs are as follow. Now, as you can see, pH is 7.2, acidosis. PaCO2 is more, so it is respiratory acidosis. So her PaO2 is 37. Patient is in hypoxemia. Now tell me what is due to insignificant part to the lung parenchymal disease or it is due to the hypoventilation. Now again you have to do the drill. You have to put the values. You have to calculate the PA, capital PA, and then you have to subtract the small PA from that. Now you know the formula. You have to multiply. Now patient is in room air. Room air means 0.21 multiply with 713 again minus, now here we have 61 multiply with 1.25. 36. Okay, now 36 means what? So this is high AA gradient. High AA gradient hypoxemia. So what is that then? 36 means high AA gradient means this is due to lung parenchymal disease or hypoventilation. Come on, tell me. Punishment Saima, you are right. This is 36. This is high AA gradient. Now, what were the causes of high AA gradient? Yes, lung parenchyma. Yes, Ali, Sumaira, Aruj, Pradeep, Alishpa, Aisha, you all are right. This is lung parenchymal cause. Lung disease. Yes, Jennifer, you're also right. Great. You all are getting experts now, and I am happy for that. Yes, Pradeep, you're right. Saima, you're right. Humaira, you're also right. Dr. Humaira, you're also right. Good. So my students are expert now. Okay, now we're having another one. We have another ABGs. 18-year-old patient has ABGs of this on 35% oxygen. Now this is the FiO2. Does he have a problem with oxygenation? Now you have to again calculate the AA gradient. Come on, let's do it, everyone. And give me your answer. 249 here minus 35 multiplied with 1.25 is 43. 249 minus 43 is 206. So our PaO2 is 206. Now subtract 136 from this. 206 minus 136, answer is 70. So AA gradient, my AA gradient is 70. Now tell me your answer. I don't know mine is right or not. 69. Okay, 69. Mine is 70. But all right, it's 70. Let's see. So, okay, tell me. So, does he have a problem with oxygenation? Yes or no? Now you have to answer this. Patient is having a problem with oxygenation. Yes or no? Okay, Ruj is saying yes. So, let's see the answer. Yes, your answer is right. Yes. Tutorial 2. What is tutorial 2? Acid base. Okay, acid base wale hum nahi kar rahe because we have already done this. Okay, so that was all about the respiratory component. Okay. Because the tutorial 2 is all about acid base balance, imbalance, because we have gone through all the exercises of acid base and the respiratory exercises are done. So that was all about our session. Now, if you, we are 15 minutes beyond our time. So I think we should end our session here. And this is the last day of our session. So thank you, everyone. I hope you have understood it well, the whole concept of ABGs. And if you have any queries, you can ask me now. If you have any queries, you can ask me, dear. Please send recording of 2 days. Yes, Afira, I will try to edit it. And then, yeah, I will, of course, I will try to edit it as soon as possible, okay? And then I will share it on my YouTube channel. That is Caps by Dr. Sairah, okay?